Okay, so thank you so much for the invitation to present as part of this illustrious panel. I see many of my current and former valued friends and colleagues in the audience, so I am very glad to be able to speak to you all. Some are experts already, and I hope some will learn something from the experience and the planning that we are making here in Kiribati. I said panel, but I want to note that it's a manel. We're all men. Of course, there are many extremely talented and very experienced women who can also deliver these presentations, but I'm privileged and delighted to present to you today with a group of fellas. Just by way of introduction for myself, my name is Dr. Jeremy Hill. I am Australian by origin, from Perth in Western Australia. I'm a public health specialist and medical doctor by training. And really for the last 7 or 8 years, I've been working mainly in the area of TB, drug-resistant TB, HIV, as a clinician, researcher, technical consultant in a variety of different areas, but in particular, the last few years in the areas of TB prevention and active case finding. So I'm going to present to you today about projects that we are currently planning for delivery where I am currently located in Tarawa in Kiribati, a country that perhaps not so many of you are familiar with. The study that I'm going to introduce is called the PEARL study, Pathways to the Elimination of Antibiotic Resistant and Latent TB, and also leprosy. We named the study prior to, we should call it TB infection these days. This is the group that I'm representing. My PA, Professor Ben Moray, known to many of you, I think, he's the University of Sydney. Our coordinator, Dr. Michaela Coleman. And bottom left is Aresi Smion, who's the Director of Public Health at the Ministry of Health and Medical Services in Kiribati. So what is the PEARL study? It's a population-wide tuberculosis and leprosy active case finding and prevention program. Kind of a partnership between a few different areas, although when in the era of COVID, so I think now we fist bump instead. It's a partnership in terms of collaboration between research and evaluation on the one side and delivering a impactful public health program on the other side. It's a partnership between the University of Sydney and the TB Centre for Research Excellence based at the Centenary Institute with the Kiribati Ministry of Health and Medical Services. And we hope to generate efficiencies or find efficiencies by addressing the coinciding epidemics of tuberculosis and leprosy in this high burden population. With our interventions, we aim to reach the entire population of South Tarawa at 65,000 over around 2 to 3 years by providing a community-based screening intervention. So the setting is South Tarawa in Kiribati. I'll show a map on the next slides. It's the most populated atoll in a geographically large and isolated or remote nation in the Western Pacific with a high TB incidence. That's across the country. The estimated incidence from the WHO report. Where I am currently in Tarawa, it's a densely populated part of the country on a very small sliver of land. And the TB estimated incidence here and case notifications are about twice that the rest of the country. We have a low prevalence of HIV and a high prevalence of diabetes and very few cases of drug-resistant TB at this stage. This is the kind of operating environment. This is from my work this morning. We're preparing, in this case, a COVID outreach. The country was COVID-free until 18th of January this year. So the first Omicron outbreak occurred over the last few months, and we have been working quite frantically to respond, put in place the measures. The location is about halfway between Hawaii and Papua New Guinea. It's a small chain of atolls in this island chain, and there are 3 island chains in the country. This is Tarawa, and the population lies along the southernmost arm of the atoll, a very narrow strip of land. There is one road from one end to the other. It's about 35 kilometers. And there are tightly packed areas of population, 65,000 people living on this piece of land. So the aims of the study are to evaluate the effect of the community-wide active TB case finding intervention plus treatment of TB infection upon estimated incidence in Tarawa, and to do the same for leprosy. So this is where I want to move into the, I suppose, the main topic for today, and in our partnership with Delft. We saw an opportunity, I suppose, in the advances in digital X-ray to generate the possibility to deliver the planned project. Through miniaturization, the systems that are now much more mobile and portable, we're using the Delft Light backpack system. We have the opportunity to reach affected communities right where the highest transmission is occurring. With new evidence that has been translated to WHO recommendations and the introduction of access pricing through the GDF and other mechanisms, we have the opportunities for scale up to reach the entire population of South Tarawa, the highest transmission and the highest burden area of the country. And using advances in the in connectivity and in technology, we have the opportunity to strengthen digital health systems to take advantage of our partnership with Delft and the use of digital X-ray and computer-aided detection. So what is the design? First of all, we will provide a screening intervention that is in a mobile clinic at community level, offering a test and treat for tuberculosis, tuberculosis infection, and leprosy. Of course, that's the flagship, the most obvious part of the intervention, but must be accompanied by other interventions and aspects of the intervention to make it work. First of all, stakeholder engagement and community mobilization to ensure that what we do is as acceptable and ready for uptake as possible. Through to community-supported TPT and impact for change in the TB program. As part of the test and treat screening clinics, we will offer systematic screening using TB symptoms and leprosy skin check, TST for TB infection, a digital X-ray with CAD using the Delft Life backpack, and a sputum sample using GeneXpert Ultra. Based on the results from the series of ACTS trials in Vietnam conducted by my colleagues at the Woolcock Institute and the University of Sydney, we intend to offer GeneXpert Ultra to all participants as a first-line screening modality. So we'll have a very sensitive screening modality using CAD and using GeneXpert Ultra. Appropriate referral and treatment will follow from the screening intervention, including single-dose rifampicin as a mass drug administration for prevention of leprosy. So what is the road to go? How are we implementing digital X-ray and computer-aided detection? In my mind, I think of the 3 components on the left: capture of images, archive of data, and interaction with the data that is generated. You can see in the center a schematic illustrating how we will implement the various components of a digital X-ray and computer-aided detection system. We have image capture with digital X-ray generating DICOM images. These images will be initially interpreted with the assistance of computer-aided detection, the Delft CAD DB product. These will generate AI heat map images and can be stored in local XNAV-based packs. These will then be transmitted asynchronously to our research archive, another XNAV installation maintained by the University of Sydney. So I think each of these things really, in the way that we have planned this intervention, planned our screening clinics, and planned our usage, warrants careful consideration. There are a lot of really helpful resources now, I think, that have been released over the last 1 year or couple of years from global partners that have interacted with the manufacturers, including Delft, the materials from Stop T Partnership and Find in particular. For us, looking at the various components, we realized early on that in the environment where we're operating with few existing resources, in fact, the hospital here doesn't operate a PACS system at all. So the images that are captured programmatically are not really archived, and therefore ongoing interaction is not possible. So we realized early on that each of these components, in terms of planning the road to go, we would need to make sure that we thought about not just procurement and the digital X-ray system and the computer-aided detection, but also the various different systems that need to go around it, both from the research side and from the program side here in Kiribati. I think it's really important to realize that the investments that we make in digital X-ray and computer-aided detection should not stay just in the TB programs. Of course, X-ray has value, as was mentioned in the introductory statements, for example, in COVID programs, but also at the primary care level, especially in a geographically remote and isolated nation such as Kiribati, where often patients do not have access to referral. We realized that we would have to interact with a variety of different X-ray systems, and so we've designed a plug-and-play design using the flexibility of the Delft systems and the standard-based architecture to be able to integrate also other X-ray platforms as will be needed over the coming years. So that's it for my presentation. We are at the moment, as I mentioned, in the midst of responding to the first COVID outbreak here. The initial activities involve a TB infection survey among school children to ascertain the annual risk of baseline annual risk of tuberculosis infection. We'll conduct a pilot over coming months and then to have launch and full scale up for population-wide delivery in the middle of the year. Thank you very much.